All right, let's talk about Chapter 13, Pediatric Hearing Loss. This is a great quote from the beginning of your chapter. I really liked it, so let me just go ahead and read it. The sense of hearing is miraculous. The ear contains the smallest bones in the human body and has specialized sensory cells that can process sounds ranging from the drop of a pin to the takeoff of an airplane. The human ear can also perceive minute changes in pitch and loudness, recognize a familiar voice on the telephone, and differentiate among the many sounds at an amusement park. In short, hearing links us to the world around us. When an individual's hearing is diminished or lost because of injury, illness, or even genetics, the results are life-altering. So let's talk about pediatric hearing loss. Hearing loss refers to a condition in which a child or adolescent is unable to detect or distinguish the range of sounds normally available to the human ear. Hearing loss affects the outer ear or the inner ear. Auditory processing disorder is a hearing loss resulting from damage to the processing centers of the brain. So hearing loss is going to be a difficulty actually hearing, whereas auditory processing disorder, as we'll talk about, is a difficulty in easily processing the information that you've heard, even though you can hear it just fine. Hearing loss among children is highly variable. The location of damage to the hearing structures, is it the outer ear, the middle ear, the inner ear? Is it the auditory nerve? And then because we have two ears, hearing loss varies in whether it affects one or both ears. If it's bilateral, it affects both ears. If it's unilateral, it affects one ear. Obviously, just having a unilateral hearing loss is a lot easier to deal with than having a bilateral hearing loss. Also, the extent to which hearing acuity is impacted. If it's a congenital hearing loss, that means that was a loss present at birth. A prelingual hearing loss is a hearing loss that is present before the child has learned language. And then a postlingual hearing loss is a hearing loss that takes place after the child has learned language. One of the coolest clients I ever got to work with was when I was a graduate student, and he had a progressive hearing disorder where I think he was 7 and he was losing his hearing, and in a couple years he was going to be completely deaf. So he had hearing aids when we worked with him, and so we were trying to get as much language into him so that his speech and language was as good as possible before he lost his hearing. So, if you have a postlingual hearing loss, you've already established language and speech, and that's going to be easier than either prelingual or congenital hearing losses. So your book talks about lots of different terms that can be used: hearing impairment, hearing disorder, deafness, hard of hearing, hearing loss, deaf, and the deaf community. Right, when we're talking about capital D deaf, we're talking about the deaf community and people working together as a group. Everybody is deaf, and they're socializing. They have their own words and terms to use, so they're truly a community. And your book talks about which, that the fact that hard of hearing, hearing loss, hearing impairment are often the terms most used unless somebody is completely deaf. Prevalence and incidence. The reported prevalence of hearing loss among children varies significantly depending on the criteria used to identify the loss. Some studies have shown that up to 15% of children will at one time experience a hearing loss, either due to things like otitis media or wax, which we'll talk about, or a more permanent loss. The term educationally significant refers to a hearing loss that is serious enough to impact a child's ability to perform well educationally. And here we have to talk about the impact. We have to talk about the child's integration into the hearing community, right? So how does it impact them educationally? Does it really place a burden on them to learn language, to learn everything they need to learn in school? Are they able to integrate into the hearing community socially and functionally? Are they able to, and do they want to integrate into the deaf community and be a part of the deaf community and learn sign language? And then also, what is their communication development like? Is it progressing normally? Are they having difficulties? How does that work? Hearing loss in children and adolescents is typically classified according to its etiology, its manifestation and impact, and its severity. Does it have a genetic or environmental cause? What is the age of onset of the hearing loss? And what type of loss does the person have? So genetic or environmental causes. Genetic and environmental factors that can result in hearing loss are numerous. In many cases, the specific cause is unknown. You can have an autosomal dominant hearing loss where you have one parent who is deaf, and then you have a 50% chance of being deaf yourself. There's also an autosomal recessive hearing loss where one of your parents has a recessive gene. They might not be deaf themselves, but you have about a 25% chance of being born deaf with an autosomal recessive hearing loss. Age of onset. The age of onset for hearing loss is typically differentiated into developmental or acquired. So is it developmental or present at birth? Is it acquired? Did it occur sometime after birth? And like we talked about before, is it prelingual, where the loss occurred before language is acquired, or is it postlingual, where the loss occurred after the language was already acquired? Type of loss. Type of loss identifies the auditory structures that are affected. A conductive hearing loss is a loss which is caused by an issue with the outer or the middle ear. A sensorineural hearing loss is a loss that concerns the inner ear or the auditory nerve. And a mixed hearing loss can be or is when someone has both a conductive hearing loss and a sensorineural hearing loss. So maybe they have a conductive hearing loss, they have a middle ear infection like otitis media, which we'll talk about, but they also have a sensorineural, more permanent hearing loss, and they have both of them. In classifying the hearing loss of a given individual, experts consider all these sources of information: the cause of the loss, the age of onset, and the type of loss. Some children with hearing loss experience loss of hearing acuity, referring to the precision of hearing at different levels of loudness, right? So maybe you can't hear really well if something's really quiet, or you can't hear really well if something's really loud, but you're okay hearing, if it's an average level of loudness. More problematic than that is a decrease in auditory comprehension of spoken language and speech perception, which can accompany hearing loss, right? So if you're not able to comprehend spoken language, right, that's going to have a big impact on a child and an adult. Hearing loss is also classified according to its severity using the decibel system named after Alexander Graham Bell. Decibels are the standard unit of sound intensity. It represents the differences in loudness available to human hearing, from the threshold of sound at 0 decibels, which is the drop of a pin, to the threshold of pain between 120 decibels and 140 decibels, which sounds like a fire alarm close to your ear, right? So that threshold is, where can you hear? Can you hear at 0 dB up to 120? Can you hear at 20 dB up to 140? Where are you able to hear? And then an audiogram is going to be a visual representation of your hearing ability. And there are some good examples of that in your textbook chapter. So right here we've got an audiogram, so that the black line is at 0 decibels. Normal hearing, though, is even if you can begin to hear at 20 decibels, you're still within the normal range of hearing. So this is a representation of all the speech sounds. So the z and v sounds are produced and heard at around 20 decibels. So you're only going to be able to hear that if you can hear at 20 dB. But if you can't hear up until 40 dB, right, you're going to miss a lot of the sounds. And if you can only hear at 60 dB and have a moderate loss, you're going to completely miss pretty much all the speech sounds and make listening to speech and responding to speech really, really hard. There are 3 types of hearing loss: conductive, sensorineural, and mixed. Conductive hearing loss. When sound is not conducted efficiently through the outer or middle ear, the result is an attenuating or a reduction of the sound heard. Children who have a conductive hearing loss, whether it's temporary or persistent, experience this attenuation of loudness. So often these kids are able to hear, but it's, much quieter than otherwise. Often conductive hearing loss will be the result of, it could be something like wax in their ears, or it could be otitis media, which is where you get fluid in your ears that becomes infected and hardened, and it becomes almost not impossible to hear, but much harder to hear, as your auditory bones can't vibrate with this sort of hardened goo in your ear, and you need to take antibiotics to then get the infection away and get it back to a liquid where it can drain out your ear. There's also the idea of bone conduction, which is where even if your ear is filled with wax or filled with fluid, your skull will actually pick up the vibrations of sound and will help to vibrate your inner ear. So even if you're completely blocked up in your outer or middle ear, you can still hear a little bit through bone conduction. Children frequently experience conductive hearing loss, which can usually be reversed. Wax buildup can occur frequently and block sound transmission, as can otitis media, like I talked about, which is a middle ear infection, which makes it hard to hear as well. Sensorineural hearing loss is the most common type of hearing loss, and that's because it's relatively permanent. It results from damage to the cochlea or the auditory nerve that travels from the cochlea to the brain. Even though sensorineural disorders are thought of as a decrease in overall loudness, they are also associated with a decrease in speech perception and a decreased ability to distinguish speech from background noise. So maybe I can hear someone talking, but it just sounds, the same as the hum of a fan or something like that. Most often, sensorineural hearing loss is present at birth as a congenital hearing loss. And the biggest risk factors for congenital hearing loss are serious illness, drug use, or other problems of the mother during pregnancy, in utero infections, including CMV, herpes, toxoplasmosis, syphilis, and rubella, and cause of deafness in known cases can be due to genetics and heredity, can be due to pregnancy-related issues, or post-birth disease or injury. Mixed hearing loss occurs when both conductive and sensorineural hearing loss are present. A mixed hearing loss typically includes a permanent reduction of sound, which would be the sensorineural hearing loss, as well as additional temporary loss of hearing from the conductive component. Assessment for hearing loss in pediatric population requires a multi-tiered approach. So we're going to talk about the assessment process and the importance of an accurate diagnosis. The assessment process includes referral, screening, a comprehensive audiological evaluation, and a hearing aid evaluation. Early diagnosis of hearing impairment programs are present in most states. Their goal is to detect hearing loss at birth while the infant is still in the hospital. In the toddler and preschool years, children who exhibit developmental delays in communication, who have a hereditary predisposition to hearing loss, or who develop diseases or disorders that impact the auditory mechanism, should also be referred for a hearing screening or evaluation. Screening generally falls into two categories: infant screening and conventional hearing screening, depending on the child's age. Infant hearing screenings, also called newborn hearing screenings, are completed at birth and involve specialized testing that's typically completed before a newborn leaves the hospital. So when the baby's born, usually the day after they're born, they are taken for a minute and given a hearing screening where they are able to measure the cochlea when it receives sound, and when it transmits sound to the auditory nerve, actually gives off a little bit of an echo. And so they are able to screen and test to see if that echo is coming back, to know whether or not the infant has received the sounds that are transmitted to them. It's actually pretty cool. A comprehensive audiological evaluation assesses the type and degree of hearing loss, speech discrimination, and auditory perception abilities in quiet and noisy conditions and any other concerns. And we're going to do a complete case history, interview and observation, an otoscopic examination, audiometry, and look at objective measures. All right, the hearing aid evaluation. An audiologist who identifies a hearing loss in a child works with that child and the child's family to determine the most appropriate avenue for habilitation, right? So one option will be a hearing aid. And we're going to do a probe microphone measurement and an electroacoustic evaluation to determine the kind of hearing aid the person needs and the level that the hearing aid needs to be set at. Hearing loss is an invisible disorder. There's typically no outward physical sign that a problem exists. This complicates the identification and treatment of hearing loss among children of all ages. So a lot of times parents aren't sure whether or not their child can hear, right? Because very early on, they're not going to respond to their name anyway or any words. And sort of as time goes on, parents are going to start to realize, they're not really responding to sound the way I would expect them to. And so, if we're talking about a diagnosis, you can have a false positive where it comes up that the child has a hearing loss when they really don't. That's a false positive. Or a false negative where they actually pass the hearing screening. They say there's no problem, but in reality, they actually do have a hearing disorder. How is pediatric hearing loss treated? We're going to talk about communication choices, amplification and listening devices, aural habilitation, intervention principles for infants, toddlers, and preschoolers, and for school-age children. All right, communication choices. The overarching goal of all interventions for pediatric hearing loss is the development of healthy, socially, and emotionally balanced individuals who are able to integrate fully into society and lead productive lives. So we can talk about capital D deaf versus lowercase d deaf. So if I'm capital D deaf, I'm part of the deaf community. I know sign language. I know other deaf people. Maybe I go to a deaf school and I'm really integrated into the deaf community. Versus lowercase d deaf, where I might be deaf, but maybe I have a cochlear implant and I go to a regular school. I don't know sign language and I'm not really involved at all in the deaf community. Amplification and listening devices. Many children with mild to severe hearing loss are fitted with amplification devices. Data from Gallaudet Research Institute shows that 59% of students and youth with hearing loss use hearing aids for instructional purposes. And that can be hearing aids, assistive listening devices, like maybe you have a hearing system on your desk, your teacher has a microphone and it gets amplified, or the child could have a cochlear implant where a implant is made in the child's skull that helps to work as a cochlea to fire the acoustic nerve so the child can hear. Aural habilitation. Hearing loss among children and adolescents requires individualized intervention. The goals are going to be ensuring an appropriate listening environment, maximizing audition, so maximizing as much as they can hear, and supporting listening development, so really working with them to be a good listener and understand what they're listening for. Intervention principles for infants, toddlers, and preschoolers. Early intervention, we want to get intervention going as early as possible. It's going to be most helpful for the child. We want to involve the parents as much as possible. So, right, we can't just have therapy for half an hour a week. Parents have to be on board, and therapy and involvement has to be going on all the time. Things have to work in a naturalistic environment, right? It doesn't matter if the child can hear in their audiological evaluation. It matters if they can hear in school. It matters if they can hear at home. It matters if they can hear on the playground, right? Those natural environments are what is important. Social interaction, right? Can that child interact socially? Can they talk? Can they listen? Can they hear? Can they do everything socially that's appropriate for their age? And we want functional outcomes, right? If a child can hear at 40 dB, what does that mean, right? Are they able to hear speech? Are they able to produce speech, right? So it doesn't really matter what their level of hearing is. What matters is what they're able to do. School-age children. School-age children diagnosed with an acquired hearing loss or an undetected congenital loss have established audition, speech, and language skills. So these kids already have some speech and language skills going on. Intervention principles for them will be an effective means of communication, right? So will that be speech? Will that be sign language? How are they going to communicate most effectively? Self-advocacy, right? Are they going to know? Are they going to be able to raise their hand if they're not able to hear their teacher? Are they going to know how to change the batteries in their hearing aid if their hearing aid breaks? Or to take it to the speech language pathologist in the school who can fix their hearing aid for them? If they're being teased and bullied, are they going to be able to go to a teacher, go to a speech language pathologist, go to somebody, go to a parent for help? Are they going to know what to say if one of the kids in their class says, "Why can't you hear?" Are they going to cry and get upset, or are they going to have a really good answer for that they are deaf or hard of hearing or whatever their answer is, and just be able to move on? Is really important. So lots of self-advocacy is huge. And also literacy. We want these kids to be able to read and write as well as possible. That's going to really help them if they have a hard time hearing. All right, so now we're going to talk about auditory processing disorder. This is a type of hearing loss that adversely affects an individual's processing or interpretation of auditory messages. So these kids can hear sound, they just can't process that sound. An individual with APD has problems in one or more of the following aspects of auditory processing. They have trouble with sound localization and lateralization with both ears, right? So where's that sound coming from? Who's talking? They have trouble with auditory discrimination, right? Can I hear the difference between a P and a B, a D and a T? Recognition of patterns of sounds, right? So long sounds, short sounds, differentiation of the temporal aspects of sound, right? So which sound comes first? Reduced auditory performance when the message is incomplete or when competing acoustic signals are present. So if I played, a recording of me talking, about this lecture in your right ear and then music in your left ear, right? Are you going to be able to still listen to what I'm saying? Someone with auditory processing disorder would not be able to do that. The two things would blend together. They wouldn't be able to hear the music and they wouldn't be able to hear me talking. APD is a neurological problem in which a child has difficulty interpreting and processing auditory information even though hearing acuity is intact. Often the child will behave as if a hearing loss is present, although it's not. They're going to show problems following complex multi-step directions, especially if they're given verbally or auditorily. They're going to exhibit difficulties with reading and spelling performance, right? So when we read, we're often sounding out the words, right? So if you can't hear, how do you sound out the words? It's going to be really difficult so reading and spelling is going to be hard for these kids. And so that's going to be difficult. Reveals degraded listening and audition in noisy environments or with competing auditory stimuli. So that's what I was talking about before. If there's other competing sound going on, they're going to have a real difficulty paying attention to their teacher or listening to what they need to listen to. They're going to appear to seek out visual cues from the environment, right? So they're going to look for, all right, who's talking? And I didn't hear what the teacher said, so I'm going to look around and see what other kids are doing and try to copy what they're doing, and hopefully that'll be good enough. They're going to have a history of fluctuating hearing loss, including middle ear infection. So even though auditory processing disorder isn't really about hearing loss itself, many of these kids do have some hearing loss going on. And they're going to have difficulty staying on task, finishing assignments, and working independently. So one thing that a really good audiologist or an auditory processing disorder specialist is going to do is, can they tease out, is it auditory processing disorder or is it ADHD, right? What's going on here? Because they can look very similar. Scientists do not fully understand the underlying process of the auditory processing mechanisms or the ways they malfunction to result in communication disorders. Consequently, the specific cause of auditory processing disorder is unknown. There's currently no gold standard for identifying the presence of an APD, although an audiologist does have a set of tools to study auditory processing capabilities. The assessment tasks examine sensitivity to the temporal ordering of sounds, the ability to listen to sounds when they are degraded or have other sounds competing, and the ability to listen to different stimuli in both ears simultaneously. Currently, treatment for APD focuses on reducing the symptoms of the disorder. The most common symptoms cluster into 4 areas of concern. Behaviors, right? So if I'm not able to understand what you said and I'm a kid, I'm going to act out and have behaviors that are going to make it even harder for me to understand and pay attention. Literacy, right? How good, like we said before, if you have trouble processing speech sounds, reading is often linked to speech sounds, and so literacy is going to be hard. Over linguistic ability, the child's overall language ability is going to be tough. If you're talking to me and I can hear you, but I don't know what you're saying, right? That's going to really impact my language abilities. And then overall organization, right? If they have a hard time with, hearing, processing speech sounds, right? How good are they at being organized when they come into the classroom? Do they put their coat on the back of their chair? Do they sit down? Do they get out a pen and pencil? Are they ready to listen? Are they able to find things in their book bag, or are things just all over the place, which is going to make it a million times harder to pay attention and understand what they're supposed to understand? And that is the end of chapter 13.